Okay. And you have to stand in this area here. So if you walk out of the frame, we're gonna make you come back. For those of you who don't know me, I'm Chris Bovis. I'm the bariatric coordinator, and in the unit across the hall. And Dr. Saradih is an internal medicine doctor who is board certified in bariatric medicine, and his office is on the second floor. He has taken care of our patients when they're in the hospital for, 10 years probably, and he sees anybody that's in with having their surgery that has diabetes or problems with high blood pressure, high cholesterol, any other medical problems. And since Greg had to go out of town and couldn't be here, Dr. Saradih agreed to come pinch hit. He was going to talk a little bit about some bariatric medicine issues, and then we'll open it up for questions. So just save your questions towards the end. A lot of you know him. A lot of our patients have switched to him for their PCP because he does understand bariatric surgery patients so well. Yeah, I'm going to plug you.
Well, I'm glad to see everyone here today. And I think I've seen most of you, at least maybe the gastric bypass surgery before I've taken care of in the hospital. And some of you followed me out in the outpatient setting. I'm glad to be with everybody here today. And before I open, for anybody, to ask me questions, I would like to talk a little bit about weight loss process in general. So I think for somebody undergoing bariatric surgery, they need to know these facts so it will make their weight loss process smooth, and they know what to expect down the road, and they try to work proactively in order to get to their target weight. So she told me just to come and present today, so I did not have enough time to prepare for something, but I would like to talk about the weight loss curve in general. Bariatric and non-bariatric patients, like bariatric surgery and for people who wishes to lose weight without bariatric surgery, okay? So, and I asked Chris to do it this way today, so maybe we just break the routine and take it down. Sometimes it helps, by the way, to break the routine. So, when people tend to lose weight, so they have a weight problem and they want to get to a target weight, it takes time. We build the fat process over years. It's going to take time to mobilize all the stored energy in the body fat and to lose weight. So usually when we draw the curve, I don't know if you can see this, Laura, can you see this?
Perfect.
So we do, this is the weight, and this is time, and this is going to be in months. And when people want to lose weight, so they try hard no matter what intervention that they do. So they lose weight, so we know that they lose weight, and then they reach hopefully their maximal weight loss point, okay? And then they try to keep their weight down. Now unfortunately we know for a fact that people, and everybody tried this before they underwent surgery. They lose weight, and then what happened is that they reach a maximal weight loss, and then they started, boom, put weight back again. Some of them even they reach to a weight that they had before they started the weight loss process. Is it something usual or unusual? Everybody tried this before. We lose 30, 40, 50 pounds, and then boom, we're back to where we started again. So what's good about weight loss surgery is that, by the way, this is 6 months process, and I'm not talking about how much weight, probably this is, we're talking about 30, 50 pounds. That's based on somebody who's 300 or above, they lose, we're talking about in medical term, if you lose 5 to 10% of your initial weight, so if somebody is 300 pounds and they lose 30 pounds, that's a very good outcome, because their diabetes, their high blood pressure, their cholesterol, their sleep apnea, everything gets under control. Now, the problem is that we lose weight, but we're having difficulties maintaining the weight. And the key in weight loss is not to lose it, because everybody can lose weight. The key is to how to maintain weight loss for a long period of time. So this is for somebody who is intending. So when we talk about the curve looks like a J curve. So there is down and then it goes up again like this. Now bariatric surgery, which I like about bariatric surgery, that makes this curve steeper, so people lose more weight, but the same thing applies at the end, that when people lose weight, they get to maximum weight loss. So we have weight loss phase, and then we need to have a maintenance phase. After bariatric surgery, if you don't do the weight loss process right, everybody is at risk for delayed weight regain. It may not happen in 6 months and may not happen in 1 year, but if people don't pay attention, they will end up having weight gain process. So, but the good thing about bariatric surgery, as you see, we're not talking about 30 to 50 pounds. We're talking about 60% of the excess weight loss, and for some people they lose 100, 150 pounds. This is very significant. So this impacts the body more than somebody is trying to lose weight other than bariatric surgery. Okay? And you know, it would be nice for people just to keep losing weight. You know, they're trying to eat, you know, right food, protein, low calories, and they're trying to exercise on daily basis. But unfortunately, what happens is that as we lose weight, you know, the energy that we have stored over the years, stored in our body, it just gives the body enough security and stability to, you know, be in a, it is a surplus, you know, it's like it's good to have all this stored energy in the body for years. Your body does not want to lose it. Unfortunately, when you lose the weight, your body turns against you. And I'm talking about a very complex process in your body. We're talking about, you know, hormonal and chemistry changes that happens in your stomach, it happens in your brain, and it happens in your fat cells. So I'm just gonna, so we have the guts, we have the stomach, and we have your brain. I'm not good in drawing, and we have the fat cells. We have something when we lose weight, whether in surgery or not in surgery. Why we are more prone to have delayed weight regain? Because there is something we call it adaptive thermogenesis. Adaptive thermogenesis. Basically, your body, in this state of insecurity that you are putting your body through by wasting all the stored energy, this energy, fat stored in your body is like gold for the body. When you are forcing your body and mobilizing all this stored energy in your body to use it for your energy use on daily basis, now your body feels this as an insecurity, and your body turns to a conservative mode. By saying conservative mode, that your body becomes very efficient. I give you an example. If you are early in your weight loss process, you're doing exercises like you're walking for 1 hour, you could burn 600 calories, 500 calories easily. Okay, and this calories, if you're eating protein, it's going to come from the fat stored in the body. 6 months after your weight loss process, 6 to 12 months after your weight loss process, when your body turns into the conservative mode, your body will make it difficult for you to lose these calories. So instead of you can walk for 1 hour period, but instead of burning 600 calories, you will only burn 150 calories. So you are used to a diet, and you are used to a same exercise program, and then you notice that as you're going in your weight loss process, you are plateauing. You're not losing weight as before. And that's why you see that a lot of people, a lot of you, maybe those who've had surgery 6 months and above, they keep going like this, and all of a sudden they feel that they're not losing weight anymore. It goes like this way. Anybody had this experience? I mean, it is, if you are early after surgery, you should not experience that. But we're talking about months after surgery to 1 year, that you are trying to lose weight, but you're doing the same protein diet, you're limiting your carbs intake, but your body is getting to a point that you're not losing weight as quick as when you started after surgery. So this is what we say, we call it adaptive thermogenesis. One mechanism is that your body becomes more efficient as we go forward. Your body becomes conservative. Your body would let you do exercises, but at a minimal burning of the fat. So that, the body is trying to keep on the fat stored in the body. Another mechanism that happens with adaptive thermogenesis, that after surgery you're fine, you're eating protein, you like your protein shake, you like your meat, your turkey, your ham, but with time, inside your brain, we said that there is a complex process inside your brain, hormonal changes, that would start telling you, you know what, that protein is not satisfying anymore. Why don't you do something? So your body start craving some carbs. Like people would like to eat some popcorn, they would like to eat some ice cream, they want to try some hot dogs, or they want to have more pastas. This is also something, if you eat pastas now, if you eat ice cream now, like before you start the weight loss process, you will use some for caloric, and some will be stored, and the rest will be wasted. Problem is that when your body is very efficient, at the most efficiency rate, your body is thirsty to have some carbohydrates. And your body is efficient, meaning that little bit of fuel will be enough to last the day to do your activities. Meaning that if you eat sugar after time, after months, this sugar, the calories that you eat may last the whole body as a fuel, and the body would rather always, the body would give preference to carbohydrate than to fat, than to protein. So when you eat proteins, body does not like you to use the protein that you're eating for energy consumption. If you eat fat, also body will use it for energy consumption, but body prefer carbs. So if your body is asking for carbs, you're craving to eat some carbs, I know you're not eating, you're eating little, but this little carbs, the thing that you do at night, may give you enough energy to last your whole day for the level of activities that you're using. So I mean that there was no burning, and the whole key of weight loss is that you have too much stored energy in the form of fat. You need to have lipolysis, fat breakdown, in order to lose weight. So this is another mechanism. Of course, the third mechanism, that we don't feel hungry after surgery. So people don't feel hungry. They don't like, they eat just because they have to eat 3 meals. Some of them, they skip meals, which is not good, but they have to eat 3 meals. They don't feel hungry, and as we go forward, we feel hungry again. So we have to pick what we eat, and we have to be selective. And I tell my patients, I think if anybody follows with me here, this is actually what we see it, and when we see it in real life, and this is months after surgery, we slow down in our weight loss process. You get frustrated, you're not eating, you're doing your exercise, but I'm not losing weight. But I'm just telling you this because this is your body tendency to fight your effort to lose your target weight. What you need to do as you go forward is not just to feel happy that you have lost enough weight. No, you need to keep working hard. You need to exercise more. If you were doing 30 minutes in the beginning, 6 months after weight loss process, you need to do 60 minutes. 9 months after weight loss process, you need to exercise for 60 to 90 minutes. So we have to increase the exercise duration, and we have to focus on our protein intake. So I don't want people to get frustrated, but I just want you to know this fact, so you know that how to prevent yourself from getting into a plateau as we go forward, and to make sure that you are just losing weight. This is the way that you can force your body just to keep losing weight. Of course, when we do sleeve or a gastric bypass surgery, we have a small stomach, so always the amount of food that you're eating is not going to be much because you have a small stomach capacity. But if you fill that stomach capacity with carbs, people who like to drink shakes and liquid that has too much sugar in it, this is going to give you enough calories, enough energy for the body to use it for the daily use, for the daily needs, and you won't lose enough weight. So we have to be, and that's why I think if you talk to Chris, protein, protein, protein. If you talk to Laura, protein, protein, protein. If you talk to anybody, protein, protein, protein. So this is what we call it adaptive thermogenesis. We have all to know about this, to be proactive, to get to our target weight loss without having any difficulties. So, and we are proactive because we want people, as they lose weight like this, they get to their target and they have to maintain it like this. It's okay if you want to go up 3% or something, but you have to be proactive. And by the way, this adaptive thermogenesis, it lasts usually from 6 months, or let's say from the maximal weight loss, it takes 1 to 2 years for your body to forget about adaptive thermogenesis. So 1 to 2 years to become a new Carol or a new David, that your body will not fight you back to get you to the level before surgery. So, but then it's going to be easier after that, hopefully, But by that time, somebody to be on exercising every day, 60 minutes, focusing on the protein, it becomes a habit. So it takes us 1 month to change our habit. We're used to do something, on daily basis. It takes us 1 month to change your habit. Let's say, to come to the hospital and use the stairs in order to install it in your body, to use the stairs to go upstairs. It takes 1 month to change your behavior, and it takes another 1 to 2 years to make it a part of you, like culture, like rooted in you. So weight loss process is not easy. And for people who think, well, thanks for the surgeons, thanks for surgery. Yes, surgery will take you from island and will put you on another island. But for you to stay on the other island and to look healthy and to protect your, lean body mass, skeletal muscle, surgery by itself is not going to get you there. That's why, support group is very important. Dietitian, when you meet with dietitian, is very important. You see a physician is very important. As we go downward like this, for males and females, so there is 2 phases, where there is weight loss phase and there is maintenance phase. The process has to be smooth. And there is an average for people. When you see a number of patients, you can tell that this is this amount of pounds that you need to lose in this period of time. During that period of time, we need to make sure that there are no barriers for weight loss process. I'll give you an example. I saw a patient, and I'm not talking about, if it's somebody, I'm just saying this in general. I see this a lot. They have done a laparoscopic band surgery. They came back for a sleeve, and they came the 3rd time for a gastric bypass revision. When I looked at their medication, they're taking Remeron. They're taking, I'm just going to mention these medications because they are well known to cause significant weight gain. Remeron, Depakote, somebody taking Depo-Provera, Paxil. My point is that these are common problems for somebody who has weight problem, migraine, mood swings, anxiety and depression, insomnia at night. These medications, they need to be looked at because sometimes you are trying to lose weight actively, but there is something that you're taking that is making you gain weight. So what's the point of your effort to do? So before we lose weight, we have to make sure that you don't have any barriers to prevent you from losing weight smoothly. And the first barrier could be your medication that you're taking. Some physicians in general, unless you actively study about this, they're not going to link between, Depakote and weight gain. You have headache, I want to give you something to make you, headache-free. I give you Depakote. Well, Depakote, guess what? 1 year or 2 years, patient has gained 20, 30, 40 pounds. Same thing for birth control. Give a shot, every 3 months, you don't have headaches. They gain weight. Remeron, we give Remeron for somebody who's losing weight unintentionally, unexplained. We give them Remeron because we want them to gain weight. So if I see somebody having weight problem, why should I give him Remeron? It just make him gain weight, more weight. So unfortunately, we as a physician, I'm gonna speak that loudly, that we are not. When we treat conditions, we treat symptomatically. You have lacking sleep, I treat your insomnia. We don't look at the cause of your difficulties falling asleep. We don't look at the cause of you having recurrent migraine headache. And I am sure for people of you who have lost significant weight, migraine gets better, sleep apnea gets better, sleep gets better, energy level gets better, desire for sex gets better. Everything gets better after people lose weight. So when we look at weight loss process, we need to make sure that there are no barriers for weight loss process. For males, I'm just going to say that in general, sometimes they're trying their best, they're eating the right food, they're doing exercises, but they're not losing weight. Then we have to look at a very common conditions, hormonal things that will prevent them from losing weight. Thyroid problem. If they have lack of some hormones in the body like testosterone deficiency. If some of them, and I'm going to say that this is in general, we don't sleep at night, we like to stay on TV, and without paying attention, little bit of snacking here, snacking there. We think it doesn't count, but by the end of the day, it counts hugely, especially when we know that the body becomes very efficient with time. Female, same things. They could have thyroid problem, they could have a problem, hormonal changes that could prevent them from losing weight. So we just need to make sure that your weight loss process is smooth, there is no barriers, and then you have to be proactive in preventing yourself from getting into a plateau. So I'm going to stop here and then leave it for you guys to ask questions. No? Go ahead, yes.
Type 2 diabetic, 30 years, gastric sleeve 2 years ago, still not off of insulin, down to 1/8 of what I was taking pre-surgery. Will I ever achieve?
Very good question. Type 2 diabetes. Now we know that bariatric surgery, especially the gastric bypass one, and gastric sleeve, dramatic diabetes control. Now you did mention something about having diabetes for 30 years. And I just want to give you an information that, I've been also practicing for years. And particularly diabetes, they keep talking about, pancreatic transplant, new medication in the market. I don't want to name the medication. Yes, they help in weight loss, but the thing as a medical doctor that I've seen that really help patients get cured from diabetes is bariatric surgery. I've seen it. They're taking a couple hundred units of insulin per day, short and long acting. The day after surgery, they only take 1/10 or like maybe 20% of the dose that they were taking before surgery. Now there is one thing that I want you to know about diabetes. By the time we diagnose diabetes, like by the time we say that this patient has diabetes, they have already lost 30% of their pancreatic function, okay? That's by the time we diagnose diabetes. We have lost 30% of the pancreas function. And in your situation, you've had diabetes for 30 years, so I expect, I'm hoping that your insulin requirement is better than before.
It's 1/8 of what I
1/8 is perfect. And I think have you reached your target weight or not yet?
Yeah.
So hopefully, that you will eventually reach your target weight, so you will continue to lose some weight. It will get better. But I just want to tell you that some patients, they don't get off insulin, not because the bariatric surgery is not helping. It is because the time that they did bariatric surgery has already been late enough that they've had significant, dysfunction to their pancreas. So they need insulin because they are lacking insulin in the body. So like your 80% improvement happened because you have lost enough, fat deposited in your body that made your insulin sensitivity better. Am I clear? Did you understand me? Okay. So I'm hoping that if you lose more weight, that you will be off insulin. Now, something that you need to discuss with your physician is that, how much, can I say how much Lantus you're taking?
I don't take Lantus.
You don't mind
I
it?
take a Novolog.
Novolog?
And I take 30 in the morning and 20 at night, and I need about 3 to 5 units of Novolog late in the afternoon.
You're talking about the mix, right? You're taking the
Yeah.
70-30, just the short
They're
acting?
separate.
Well, I don't know.
The Levemir I take in the morning
Uh-huh.
and evening. Yeah.
Yeah, okay.
I
I don't want to make it personal, but I'll tell you something.
I don't take Lantus.
Now, this is the time after you have lost significant weight that maybe some of the oral medication for diabetes would work much better now than earlier in your, before surgery. Like, metformin, Victoza, a lot of medication in the market, Invocana, that makes you actually lose weight and help your diabetes till you become, hopefully, insulin free.
We're also looking at thyroid imbalance, which I've had for longer than I've had the diabetes, but it's not balanced good right now either. I'm on thyroid medication, but they're both going down instead of anything coming up, so they've thrown in Armour thyroid along with the levothyroxine.
Sure. Now, again, we expect diabetes to improve, but I'm not quite sure that thyroid should improve after bariatric surgery. It's more like an autoimmune process, and it has nothing to do with bariatric surgery. So, questions?
I had sleeve in June, and I've actually been healthier than I haven't gotten as many colds or anything this winter, but NyQuil is like my favorite thing to take when I'm sick, and it helps me sleep. I have not taken it. Is there a reason why that's bad for us?
NyQuil.
Because it's not on the list of what we can take.
NyQuil.
Well, I know it has alcohol, but some people take
What else in
drink
NyQuil?
alcohol.
What else? Does it have antihistamine in it, right?
Yeah.
It has, okay, people don't know this fact. Now, in general, if we're going to talk about groups of medicine, Benadryl. Benadryl is a very common drug that people use it. They don't even mention that to their doctors that they take this medication to help them sleep. Benadryl is an H1 blocker. It is an antihistamine. It is a medicine that causes weight gain over a long period of time. Now, nobody tells you that. Anybody tells you that? No. It just, but Benadryl studied, it's not a good medicine for people who are wanting to lose weight. So I tell my patients antihistamine, Claritin, and Zyrtec, they're good medication. Unfortunately, we live in the Midwest. We have severe allergy symptoms, but I would rather for patients to breathe and, enjoy their life and take the medicine rather than just not to take the medicine and live miserably and try to lose weight. When we talk about weight gain, after these medications, we're not talking about significant weight gain, but it's something that we need to look at when we see somebody is not losing weight. So we need to look at the barriers and try to take them off. So I don't know if I answered her question.
I know NyQuil has alcohol in it, but I've had like 2 half a drinks in the last almost year. Some people drink occasionally, and
No problem,
I don't really drink, but I've been nervous to do it.
I need to look at that list, but any comments?
But I like
Yes.
my NyQuil. when I'm sick.
I don't think you're
When
doing
I'm
great.
sick.
You're losing weight. You feel energetic. We want people to become normal eventually with time.
Mhm.
We don't want people to increase their you're not supposed to do this. You're not supposed. You shouldn't. So I think NyQuil should be okay.
And it's
Yes.
occasional, because
Yeah,
like I
it
said,
should be okay. I'm not quite sure why NyQuil is not.
Okay.
Maybe earlier, After the treatment, you're taking pain medicine. They don't want you to take any sedative medicine. I don't know. I need to look at the one who put that list. You know.
Since June, I've only had a sore throat one morning and a runny nose for a couple weeks.
Good for you. That tells you that your immune
Yeah.
system
Right.
is much better than before.
Right.
And you know, a lot of things that we don't know about bariatric surgery, but we already know that we cure diabetes, we cure hypertension, we stop taking cholesterol medicine, we stop using our CPAP machine. I've had patients in the office, you know, their pulmonary doctor was amazed that they were on oxygen all their life. After they lost significant weight for COPD, they're not using their oxygen. We know that we prevent arthritis, you know, surgery. We know that back pain gets better. I know from seeing patients that fibromyalgia gets better. I know from patients that their bipolar gets better and their medication, instead of taking several medicine, they take few medication or they stop taking medication. So I know from studies that people who undergo bariatric surgery, they decrease the risk of having cancer by 60%. 60% cancer reduction.
Also because they stopped drinking soda.
Well, again, I mean, a lot of things. I mean, I know one thing, that we live in a country with too many temptations, big time temptations. I know another thing, that weight is becoming the norm. Weight problem is becoming the norm. Either ourselves, our families, our kids, we have all weight issues. I know that in order to keep in shape and to get yourself in a health condition, you have to struggle. Not only you who are undergoing surgery, a lot of people, wherever they go, weight is an issue for everybody. So, yes, I mean, we have a lot of things that cause a bad impact on our body, including sodas, including the sugar that we eat in our meals.
Mm-hmm.
You know, I don't want to say this, I'm trying to be politically right, but when we look at the curve for weight problem, obesity in the United States, it goes back to 1970s, 1970, when we started having weight problems. And that's the time, actually, 2 or 3 years before that, when they introduced high serum fructose.
Yes.
Yeah, they're using fructose instead of sucrose. So we have that sugar too. So, and people are talking about fructose as if it is an alcohol impact on the body. Fructose damages your liver to a point that you end up having metabolic diseases. Now, it is big time discussion. I don't think we need to go there. And maybe part of people losing weight that they're not eating sugar, so they're not getting exposed to fructose. That's why their diabetes is getting better. They're losing weight, their blood pressure is better, all their metabolic parameters gets better with time. Questions?
How do you determine, if you have diabetes, how do you determine which surgery would be best for you?
Okay, both are very good. Okay, I want to explain two things. We're talking about hormonal treatment. So, and I'm just going to draw the pictures.
Okay.
In general, if you're diabetic with insulin resistance, high dose of insulin, doing the gastric bypass surgery would be best outcome-wise. Sleeve is a new procedure coming to the market. Sleeve, and a lot of sleeve patients here, they don't take medication anymore also for diabetes. So if you want to just put it, which is better for someone who's diabetic, gastric bypass is much better. But that doesn't mean that sleeve is not good for you. Sleeve is good, but if you want to have a better outcome, because you're diabetic, go with the gastric bypass surgery. I want to explain another thing to you.
Okay.
So this is the stomach.
Do you need a new marker?
Yeah, I think it's
Hold on.
drying up.
Are you good?
I'm good. It's good to see you.
While she's getting the marker, I know this is a very general, you can't give me a specific answer, but I want to ask you, if you had 100 pounds that you needed to lose after the surgery, and how many months would you kind of give as a guide that if you stuck to it to the letter that you would lose it?
Okay, I'll tell you in general. We have like curves. And you know, curves, it's not like I'm drawing the curve, but from seeing too many patients, I can tell. I look at the patient and tell that patient what to expect in the next couple months to lose. In general, the the bigger the person is, okay, at the beginning, the more likely that they will lose more weight. So their weight loss is going to be steeper because you're making the stomach small size for everybody. So you are restricting calories for the bigger guys more than the calories that you are restricting for the intermediate size, you know, whether male or female. But if you, so they lose more weight in the beginning. Males, they lose more weight than females in the beginning. Males are, they have, it's a lot of things, you know, a lot of factors. Males, they have more lean body than females. They have more muscle mass than females. They have higher, genetically higher resting metabolic rate than females. So the rate of burning for males is already higher than females. Now, if you look at normal, we don't want to say, I mean, if you take two average weight individuals, females, they have more fat percentage than males, but males have more protein than females. That's the way they were created. It's important for their body. Now, when it becomes excess, that's when it causes problem to the, I think also another thing that I want to add, that when males have excess fat, it is more harmful to their body than female having excess fat if we say we talk about the same percentage. So a lot of things, a lot of factors. But if I want to answer you, so you take it like this, in the first 6 months, people easily, for average person should expect 50 to 60 pound weight loss. By 1 year, you know, I think 100 pounds should be something that can be done. Okay, so, and you know, there is a honeymoon area, honeymoon period after bariatric surgery. And I tell my patient, you have to take advantage of that time. Honeymoon, it's not like you expect yourself to keep going, losing weight, and we talked about this here. 6 to 12 months. If you don't do your right, you know, the things that you need to do, eat smart, exercise, that's the time that you will lose significant weight. After that, it should be a maintenance phase. I mean, if you want to lose weight after that, it's just going to be hard because your body is very efficient. We talked about that.
So the goal is 6 months then to hit it hard before 6 months. Is that what you're saying?
Okay. The goal is in the first few months after surgery.
Yeah.
When you're hunger, that's, you know, we talked about this.
Right,
The
right.
body becomes very efficient after 6 months.
Right.
So the goal is
Okay.
within the first 6 months to do our best to
Okay.
come down as much as we can. That doesn't mean that you cannot lose weight after.
Right, right.
You continue to lose weight, but it's not going to be the same rate as in the first 6 months after surgery.
Okay.
As the the second 2 months, the first 2 months is faster than 4 months.
Yeah.
So as you go forward, the curve is not steep as before. So
Okay.
questions? Sorry. Okay. So this is, we draw your stomach, and whether it is this or this is, by the way, when they do, I'm not good in drawing, but I guess in the gastric bypass, they take your stomach, part of your stomach comes here, and this is the upper part of your small intestine, and then they bring the small intestine from here and hook it up here. You know that, right? So this is part of your stomach and the initial part of your small intestine. Okay? So this is how it looks, gastric bypass after surgery. I'm not a surgeon, so I'm just make it simple. And here, sleeve looks like this. So for both, and I'm going to take this piece here, okay? For both surgeries, immediately after surgery, ghrelin, which is the hormone, gets secreted from the stomach, hunger hormone, the hormone that makes us wake up in the middle of the night and go seek food, it comes down, okay? So we don't feel hungry. Now, when we do this sleeve, so we should only expect that ghrelin goes down. So that's when we do the sleeve. That's by theory, okay? I'm going to tell you what they found in clinical practice. Now, when we do bariatric surgery, they cut a huge part of the stomach, so ghrelin goes down. We don't feel hungry. And then another thing they did in the bariatric, that they pulled the lower part of your guts and they hooked it up to the stomach. This is known to cause several hormones to go up. One is glucagon-like peptide 1. I don't want to make it scientific. And there is pancreatic peptide, PP, and there is polypeptide Y. And also exontomodulin. I don't want to make it scientific. Anyways, GLP-1 for those who are diabetic. Have you guys heard about Byetta or Victoza? It's a medicine that now we use for diabetes treatment. Very effective and make people lose weight. So in this surgery, ghrelin goes down, we don't feel hungry, and we have several hormones. They go up, they make us not hungry, like they make us like no appetite whatsoever. And this hormone improve insulin sensitivity and get your blood sugar under control.
Okay.
That's why for those who are not diabetic with insulin resistance, after surgery, they are at risk for having hypoglycemia. Okay? Now that's in theory. Okay? Now when they studied those populations, they brought patients back to measure their hormonal level. They also found that ghrelin goes down here, GLP, peptide YY, and exontomodulin. They go up here, and they also go up here. But they go up here maybe 3+, they go up here 2+. Did you understand that? So both surgeries can help diabetes. If you have severe advanced diabetes, gastric bypass would be a better choice for you. That's my bias for it. And again, remember that even if we don't have these changes, we don't have these hormonal changes, diabetes treatment is by caloric restriction and by changing our diet from carbs to focusing on protein. Like, I'll tell you something, forget about surgery. All of you have gone through 1 to 2 weeks before surgery of protein shakes, which is the most horrible weeks, that, right? That's what everybody tells me. But all of you should have noticed that when we changed our diet to protein diet, everybody got better. They sleep more, they lost 20 pounds, diabetes is much better. Some people, they stop taking metformin, Lantus, and some people, they don't take their blood pressure medication. Or at least they cut their requirement to half of the dose that they were taking before. So, it's the diet what makes us. It's like if we can change our diet, life would be like heaven. Problem is that when you go on a very low caloric diet, which is the diet that you take for 2 weeks, we call it very low caloric, 400 to 800 calories per day. People barely can do it for 2 weeks. You cannot do it for more than that because you need medical supervision. You have a lot of problems. You go into electrolyte problem, gout problem, renal shutdown problem, muscle breakdown problem. And again, you bring the adaptive thermogenesis very early. If you go like for a few weeks with very low caloric diet, and instead of waiting for 6 months, people end up having severe hunger, early, so they have polyphagia, they want to eat more just to catch up with all the calories that they have lost. So there are centers in the country that they do very low caloric diet as a method of weight loss, but I am not quite sure that long term it's a good way to do it, because we talk about the same thing. You lose weight, but then it comes back again. Surgery is the only thing that have shown big success in making people lose weight and keep it down, because you're forced to change your lifestyle. I mean, for gastric bypass surgery to go and drink a glass of juice, sugar, they feel sick. They end up having dumping syndrome, so they learn not to do it again. For gastric bypass surgery, from the patient that I'm seeing, a lot of them, they come and tell me, I don't feel like I want to have sugar early, that's after surgery. From gastric bypass surgery, a lot of preferences and the changes in their life. They don't want to eat sugar, they feel sick when they eat sugar, and then they have a small stomach, they're not hungry. So surgery forces you to change your lifestyle, at least early, first 6 months after surgery. If you don't change your lifestyle, you're never going to lose weight, but you have to And you cannot crunch too many things in your stomach because you have a small stomach. But if you keep trying to crunch stuff in your stomach, with time people will end up having dilated stomach, dilated esophagus, dilated pouch. So that's why, you know, it's important just to, you know, eat smart, and when you feel full, stop. And it's important for this, you know, patients after bariatric surgery is just like to eat, to improve his body and to take his energy requirement, and not just to have fun. You know, sometimes we eat just because there is nothing to do, you know. Or, you know, some people, they, you know, and we have to be, you know, if not some people, a lot of people, food is the enjoyment that they can have in life. Maybe they're not enjoying other things, but they enjoy eating. So I think for a period of time after bariatric surgery, 1 to 2 years, we have to work hard to change this habit. At least till we become a new person, a new Smith or a new David, and then you don't have your body to fight you back, to get you back to square one. Okay?
Thank you.
Okay.
Thank you.
Yes.
How many carbs should, or not carbs, but calories should we be doing after surgery?
How many calories?
Yeah. I have a rough
Listen.
time with getting 900 in a day.
Well, that's good. 900 is very good. Okay. Of course, Laura tells you to eat 60. You get up to 60 to 70 grams of protein, right?
Right, oh yeah.
60 grams of protein multiplied by 4, it's 240. If we say 80 grams of protein, you're up to 320 calories per day. And when I said non-surgical, very low caloric diet, I said 400 to 800. You know, at below 400, it's not actually healthy for the body. But I guess after bariatric surgery, you have a small stomach, you know, that if you drink enough liquids and you do this amount of protein per day, it should be okay for you. Now, I want to say something. All of us in this country, we have stored enough energy in our body. I'm not, we are in a surplus. It's good. Actually, so we have stored enough energy in our body that we could go for a long period of time without eating. We have to drink though. So we have to make sure though we're taking essential fatty acids. So this can be with supplement. We have to make sure that we're taking trace elements, vitamins, and amino acids, essential amino acids. Can we live without carbs? Yes, carb is never essential for our body. Carbohydrate is not essential. We can live, our body can make its own carbohydrate from fat and from protein. And that's how we lose weight. And if we don't do it this way, it's going to be hard to lose weight because the body kept storing fat in a way. You know, if you want to know about how the body stores fat, so we eat, and we have, I like to draw stuff. So we have this, and we have, this is, I'm going to make it two things, genetics, and we have also here the environment that we live in, okay? Okay, so this is our own bodies. This is positive energy or positive intake to the body, amount of food that we eat, okay? And this is negative, the amount of, this is calorie. So basically amount of calorie that we eat, and this is the amount of calorie that we burn, negative, positive. And this is our body with its genetic predisposition and the environment around. So normally, we have an appetite system in our body, very complex. You know, we have a circuit that would increase your hunger, but then this circuit is matched with a circuit that will decrease your hunger and increase your appetite. If you have that balance, you eat food, you feel full, you stop, because your appetite regulation system is active. And then the same thing, those appetite hormones that makes you regulate, you know, makes you full, they go to your brain and make you move, okay? So people, they want to move and they want to burn that energy. So if you keep that balance, you're fine. You're just like person who can keep his weight. Those people, they remain with high energy. They feel like they need to burn the amount of food that they're eating. They're not eating a food excess of what their body needs. They've trained their body to eat 3 meals today. They don't wait for the ghrelin hormone from the stomach to go up to make you feel hungry, you want to eat everything. It's just balance. Once this appetite regulation get messed up, let's say this, and the reason for that could be genetic factors, so it's not always that we have to be, blame ourselves for our behavior. We have a strong genetic component in our weight loss, process, and I did weight gain process, and I did say environment because they are talking now about a new subject. They call it epigenesis, epigenetics. Like you're born with normal genetics, genes. You're not prone to become obese, but the environment around change your genetics to become an obese person later on. Okay? Different subject, maybe we can talk about it in the future. But if you have positive calorie intake and you have negative, you don't burn the calories that you take as much, all the positive calories that you take in the body, it will be stored as energy. Body stores carbs for 2 to 3 days. And then after that, it becomes fat. We have unlimited capacity to store fat in our body. So, and the direction becomes that we are becoming, if we have, we eat, it's a vicious circle. So our appetite regulation is messed up. So there is more lead for the hunger circuit than the appetite circuit. So we become less active, we eat more, then we have positive energy. This energy has to be deposited in the form of fat. And fat first, comes to our hand, arms, thighs. It goes this direction. Then comes around this, the belly. And then it comes inside the organs. Like, we have unlimited capacity. So not only in the skin, it goes around the liver, around the lungs, around the spleen, around the kidneys. And problem really happens to people that they get sick when the fat cells infiltrates their liver. So that's why when we say 5 to 10% weight loss in medical term, people lose 5 to 10%. I know they're not going to drop their weight significantly, like 100 or 150 pounds, but the 30 pounds that they're going to lose, it's going to be from the fat around the visceral organs. So that as they accumulate fat in the limbs first, and then it goes around the abdomen, and then it goes to the organ. When you lose it, you lose the fat around the organ first, then around the belly, then around the limbs. So that's why people, they get medically better after they lose 30 pounds. So just go back here. If you have too much positive energy, your appetite regulation is messed up, too much storage in the body in the form of fat, it becomes like a vicious circle. So we eat, we store, and we have to break this cycle. And in my medical, I'm a medical pediatrician, we have several medications in the market that can be used for weight loss process. There are certain category of people that can benefit from these medication. But if it comes to a point that, patients, they have significant energy stored in the body and they have comorbidities, we're talking about diabetes, hypertension, obesity, the really thing that help all these people to get rid of this stored energy in the body is bariatric surgery. This really helps. The other medication way, most of us, they have tried medication. We do medicine, it works for 2-3 months, we lose weight, and then boom, it comes back again. And nobody wants to take a pill for the rest of their life. And actually, these pills are approved for 3 months period, 6 months period, but we don't have long-term approval for weight loss medication. And by the time people, they take them long enough, then we end up having significant side effect that they pull the medicine from the market. This is America. Any questions?
So your practice, you're not a surgeon, your practice focuses on helping people keep weight off, or, most of us here have already had surgery or we're about
I am a resource, as Chris, as Laura.
Okay.
We are, you have, okay, weight loss is not a transaction. It's not that you see the surgeon, they do the surgery for you, and you are there. Weight loss is a process, and you need people to take your hand and, you know, go walk around till you get to your target. We talked about several things. You know, you could just come and listen to these things, and you know, you got the information, and you can apply it to yourself, and you can go. But it has been shown for fact that in order for people, it's a process, long process, to lose weight and to maintain their weight loss, it is not enough just to do one intervention. They have to do comprehensive treatment. That's why we are meeting here to have a support group. You know, support group is very important. Seeing a dietitian is very important. Seeing a physician who, it's like you need to be charged. You know, you lose your ambition, you lose your strength, you lose your energy, you lose your excitement. You need to be seen by someone who can charge you. You need to be seen by someone who can point to you where things is not going right. So that's what I can tell you. I mean, you don't have to see me. You know, you can come to the support group, but if you're having, you know, you're not going smoothly through your weight loss process, there is something that needs to be pointed to you. Someone else can see it and can just make you change your.
Well,
Another
I
thing.
understand your position, and I have every respect for you. I just wondered at what point someone would say, okay, I need an appointment. Are you saying you're?
I'm not here to get an appointment. No.
No.
I'm not. I am here because I want to.
I'm just trying to figure that out. So would most of your patients come to you when they're hitting a plateau or they feel like they
No.
need assistance?
Okay, patients. Okay. I have been working as a bariatric physician since 2002. But the decision that I made actually to have an outpatient practice was not too long ago, less than a year ago. I have always been the guy doing medical management. I see patients at the time of surgery. The following day, I change their medication, bye-bye, and I don't see them again. They go to their primary care physician. Some of them, they come back, and I see they're taking back the medication that I have stopped before. You know, it's a different mindset. You see your primary care doctor, that's their medicine. They want to give you medicine. They want to give you refill. You know, it's like, you know, for me, it's a different mindset. I want to see my patients. I want to take them off their diabetes medication, their blood pressure medication, monitor their medication. If they need something to smoothen their weight loss process, I want to give them medicine to make it smoother, right? If they don't sleep fine, you know, maybe nobody pays attention to this, but studies have shown that people who sleep less than 5 hours per day, per night, they are more prone either to lose weight slowly or gain weight later on. So it's my job as a bariatric physician to give patients medicine to help them sleep to facilitate the weight loss process. It's my job to pick the right medicine for them. If I see that you're taking a beta blocker, it's my job, I think, that I would think that this is not the right beta blocker for you. You need beta blocker, but I have to give you something that will not affect your weight loss process. So it's a different mindset. Now you go to a different doctor, he's not weight mindset. I'm not saying that you don't go to your primary care doctor, but it would help to have your primary care doctor and have a bariatric physician to oversee your weight loss process. And to answer your question, so I see patients at the time of surgery, and I follow them 1 week, 2 months, 6 months, 1 year, bye-bye. I mean, it's like, you just want to make sure that you monitor the progress to the weight loss process. Some they choose not to come. Some they like that somebody's overseeing, we put targets together, we agree. So it's a personal thing, it's individual. So we individualize treatment. It's a prescription. You know, 30 minutes would be a good exercise for someone, but another person needs 60 to 90 minutes of exercise. Somebody's having pain and they don't do exercises because they are hurting. It's my job to give them something to alleviate their pain because I want you to exercise, because I want you to burn. So, you know, somebody is taking medication for headache and this medicine is causing weight problem. It's my job either to change the medicine or to tell the patient to go to their psychiatrist or to their neurologist or primary care doctor and have them change the medication. And that's what we do, so basically. So there is no right timing. It just happened that I'm following patients, and we get, and today, you know, I was seeing patients, which was really fun to see patients after they have reached their target weight, and they look nice. Because, you know, at the end, it's not just you do surgery and you lose weight. You want to lose weight, and at the end, you want people to look at you and don't believe that you have done a bariatric surgery. You look healthy, you protect your skin, you protect and preserve your muscles, skeletal muscles. You know, nobody would like to be a bag of bone at the end, because if you don't do it right, you will lose fat and you will lose protein. And guess what? If you lose your skeletal muscles, if you lose significant percentage of it, it is what counts for your lean body mass. And lean body mass is what counts for your resting metabolic rate. Each one has a basal metabolic rate. We burn. I'm burning now. I'm, you know, inside, like fat and energy. When I'm talking, I'm burning. When I'm sleeping, I'm burning. And that's why maybe people, they think that, you know, they are not a fast burn. Their metabolism is slow. Because they don't have good muscle, core of muscles in their body. If you have good skeletal muscles, if you have good lean body, you preserve that lean body, it will help you down the road to keep a base of resting rate to help you keep weight off. Am I clear? So if you lose your muscles, your lean body mass goes down, your resting metabolic rate goes down, and this is also your activity rate. Everything goes down. So you become like a slow burner, easily to gain weight later on. I'm even talking about 2 years, 3 years after you lose weight. Do you want to ask questions?
Oh, no, you answered it.
Oh, okay.
It's the term you used at first, it's called thermogenic what?
Okay, thermo is heat production, burning, adaptive, you know, from adaptation. So adaptive thermogenesis. As you go through the weight loss process, you are messing up with your body norms, routine. That's why I said in the beginning, it's nice to break the routine.
Is that equivalent to your metabolism?
This is equivalent to several things in the body, not only the metabolism, but the speed of your metabolism, rate of burning, one of them, it changes.
And if you have 50 to maybe 60 pounds to lose, might it take you longer to get to that more efficient rate? I mean, after a year, maybe 2.
Well, you know, as we said, if you keep doing the right thing, you eat protein and you exercise and you have, so by the way, after bariatric surgery forces you not to have positive balance, right? I mean, you're eating how many calories per day? So actually this goes like this, down. So you're burning, you're burning, but when you eat like few calories per day, you know, this is a normal person, they would go up to 3,000, 5,000 calories per day. After sleep or bariatric surgery, your stomach is small, restrict you to take 500, 600 calories, 700, 800, 1,000. Bariatric surgery, you also not absorb part of it. So this is create negative energy balance. The amount of calorie that you're taking is not enough to support your caloric need of the body. And if you do a lot of activities, so that's what I meant by this. You just need to increase your activities, burn more. If you do this, you will always, you know, lose some weight. Of course, if you start drinking juice and mashed potato, you have a small stomach, but that will take care of you.
How do you know you're insulin resistant?
We can check, okay, clinically, in general, you can just say this. If somebody has weight problem, you know, that's actually the core of diabetes, metabolic syndrome, is that we build an insulin resistance. Now, so we know that when you have metabolic syndrome, you have insulin resistance. Now, what we don't know is how much they are resistant, and this can be reflected by the amount of insulin they're taking or by the insulin level. Sometimes we check basal fasting insulin level, and And you know, we're talking about 5 is normal. If you have more, there are people in hundreds. If 15 is like the upper limit of normal, there are people in their insulin level in hundreds. Can you imagine that? Meaning that your body is making hundreds of insulin, but it's not enough to take care of your blood sugar. So that's why you're taking insulin from before. And that's also answer her questions, you know, that she has too much insulin resistance, and the pancreas has to make tons of insulin to take care of the sugar, so and it's not able to. That means that the pancreas with time will get exhausted. So
I need to close out
Sorry.
the questions so that we have time for our small groups. So, thank you very much.